I'm delighted to welcome you to this live webinar from the Fellowship of the Postgraduate Medicine. The theme of today's webinar is Diagnostic and Digital Solutions in Response to the COVID-19 Pandemic. The FPM is a medical society which publishes two journals, the Postgraduate Medical Journal and Health Policy and Technology. Our speakers are from Sweden, and our discussants are from the UK, Hong Kong, and the Netherlands. Today's topic will be introduced by Mattias Kyhlstedt, who is CEO of Synergus Real-World Evidence in Stockholm.
The things I'm going to cover today is just talking about the project we have, a little bit about the digital solutions and the consequence of seeing other digital solutions being implemented as well. Before going into the presentation, I want to make my declaration because I think this is an area which is complex and we cannot, it's not all science, it's beliefs as well. And these are my beliefs. And because that they shape the way the things we are doing. So one, I think it is challenging with the disease transmission, either if it's before symptoms or the asymptomatic. And this is an example recently from Sweden where they evaluated 35 healthcare professionals. About 50% of them proved to be infected. 5 to 10 of them were actually asymptomatic. So I think there is a complexity in the disease transmission question. I am kind of a supporter of the herd immunity if you can combine the protection of the old and vulnerable, which is a little bit discussable and an issue of debate. I do think this is something we will live with for a rather long time and until we have vaccines or drugs coming. So that's a time horizon I have. And then I think the diagnostics linked with actions to protect the vulnerable is crucial. But this is also one of the most complex questions, which it's easier to develop a model of how to do these things. But as I was speaking to the manager of the care unit where my wife is working, where they work with severely sick patients in their home, and I asked, what do you do when you detect that someone is deceased or not? How do you do this cohort management and all of that? And it is rather simple in theory, but rather complex in reality, with the constraints of protection gears, also with the staff limitations. So it is rather complex. And I also believe that digital solutions may be the most important measure to track and prevent the spread. So that's kind of my declaration. So the project we have started, the COVID-19 Horizon Collaboration. The aim of this project has been to work together to close the gap between needs and solutions, because there needs to be a collaboration on the demand side of the healthcare, but also on the solution providers. And what we're trying to accomplish here is a broader collaboration than what we normally would see, where we work together as academics, industry, consultants, which I represent, HTA, and governments, because we have a greater good together that we want to accomplish. So that's the big picture. It's founded by myself and Sarah Andersson. My background is in consultancy, so that's what I do everyday life. Sarah, on the other side, is in the academic, working with health and welfare technology in the Mälardalens Högskola. She also has a very important background in regards to disease infection management, being the former general director of the Public Health Institute in Sweden. So she has a very relevant background for this. And just a side comment to this, that for me as a consultant, I'm probably spending 80% of my time doing this. It means that for that time, I'm not being paid. So I'm putting at risk all my income to work on that, because I do think it is important. So it is a little bit different perspective for me when all my income is normally based on what I do. And now I do things which I don't get paid for. So that is a different reality when we are chipping in from the industry side. So this is an overview of the project we have and what we want to accomplish. We are working in 3 areas. One is the diagnostics. The second one is digital health solutions for COVID-19. And the third one is the remote management of patients. coming as a consequence of COVID when we have to manage the patient remotely. And starting with the top one, the first question is how do we understand the demand and testing for different subgroups, and what's the role of the testing? Because I think that sometimes we are all wanting more testing, but we haven't really understood for what purpose. And I really think there's a lot of unsolved issues. Then we're trying to create collaborations so that in the end, we can have availability of reliable tests. We currently have a database with more than 300 diagnostic tests. And the question is, which ones of those are relevant to the question? And that's what we're working with in that track, and how to ensure safe tests. The next one is, how do we find the use of COVID-19 digital solutions? And that's what we're going to focus more on. And then finally, on the third one, about remote management of patients. The way we do this is we're trying to look at what are the needs and the solutions. So we're looking from both sides. Then we're trying to identify issues that are of importance. And then we get experts together to process the best possible knowledge. And then based on that, to do publications and reports that can be used for decision making now, but also to help shape future research agenda. Talking about digital solutions for COVID-19. So this is a summary from a meeting we had a few weeks ago, where we had experts from Denmark, Germany, Italy, Spain, and Sweden, where we discussed what solutions are available. And they are broadly in these three categories: the diagnostics, the managing the infected patients, or managing the spread of the infection. So those are the big categories. The diagnostics range from rather simple online tools to apps for symptom tracking. So there's a variety of solutions. There is some evolvement about things. How do you manage your patient remotely so that you can bring them into the ICU at the right point of time? But I think the most important part here is about how we can manage the spread of the infection. And there are some very interesting solutions in that regard. And in our meeting, we had the discussion, who is responsible? Because that's not clear. What is the strategy? How do we evaluate the performance, and what can be learned from other countries? And the key takeaway was that it is from very random to a very structured approach. So Italy is actually a country that normally may not be on the forefront of digital. They are really using this as a key measure to address their problem. And this app with proximity tracking is the key measure when they're going out of lockdown. So it proves to be of good value. And the question is, how can it be of value in other countries? So from that, we're then trying to look at and analyze what are different countries doing in this regard. And here you can see that Germany is looking at proximity tracking, France is doing it, Austria is doing it, Iceland is doing. So there's a lot of countries, and we're trying to understand what are they doing, what is the effectiveness of that. We're also documenting and sharing the knowledge from different countries. Here's a blog post about Italy, so some of it will not just be scientific, but we also do blog posts. And then from this knowledge, we're now having a webinar in a couple of weeks where we're talking about this with the digital solutions, and both looking at the proximity tracking, but also the geo-tracking that they're using in Iceland. And the aim here is that how do we benefit and learn as we walk? Because there's no time for trials now, but so how can we learn from Iceland? They started their trial April 6th. So maybe there's insights we can learn from them in a few weeks now to help guide other countries where to put their focus. So this is what we're trying to do in regards to COVID-19. Now we're going to talk about the digital health transformation triggered by COVID-19. And I would think that, describe it like this, that there's been a lot of limitations preventing the digital transformation, and the lack of infrastructure, organizational resistance, the lack of digital backbone, and so on. And on the other hand, we have had the maturity of the digital solutions evolving. So the pressure to make change has really increased. And now we have this COVID-19, where there's a big demand for remote management of patients, which is really going to tip over the need for digital solutions. And I think that's good. But the thing that we really need to ask ourselves is what we try to illustrate in this picture, is that digital health, is it a real support, inflated hope, or actually a burden? And the healthcare system in this illustration is carried out by the professionals, by the available funding and resource we have. We have an aging population that increases the burden normally. On top of that, we have COVID-19. And we're kind of, if you read media, everyone is expecting, oh, digital health, now is the time to be the real support. Reality is that it's not really always that, and that's what we need to understand. When is it inflated hope and when is it a burden? We have some things, and one of the questions we need to understand is how do we discern the required evaluation and intentionality in the implementation? There are certain things which are rather simple, like when you have replace a physical visit with a video call somehow. That's rather simplistic. It doesn't have that much complexity. But you also have the other side where you have complex things, where one of them, which I think is going to be the biggest, the shift in the dynamics between the patient and the doctor and the role that's changing there. What is the role of the doctor? What is the role of the patient? That's rather complex. And then a lot of these changes, they include quite substantial change in organization of health and social care. How do you redesign processes? How do you break structures and economics and all of that? And how do you monitor effectiveness of that? Well, that is rather complex. And then we need other measures to deal with that. And one of the topics that we're going to have a meeting about in a few weeks is this topic, that how do you utilize digital patient interaction triaging to improve the patient experience and organizational efficiency. And the picture here is from Babylon Health, which is one of the known examples where you try to use triaging. And we ask this question, is it a burden or is it a help? And from this study being referenced in the bottom here, we see that they looked at, this is teleconsultations, so it's different. But they say that in their study, that when the GP did the triage, it was associated with 33% increase in the mean number of contacts per person over 28 days compared with usual care. And the nurse triage, then it was a 48% increase. So here you have a person who's skilled, doing their best, and still that is result. So the question is this really help? Is it inflated hope or is it a burden? So what we're going to do is Professor Campbell is going to be part of this webinar. We're going to have a couple of the technology companies present what they do. And then we're going to see and have an honest discussion about how is some real value in this or is it not? Because a lot of people are jumping on board on this train, like, yeah, we need to do it. It sounds very exciting, but if it is that they suggest that maybe 50% of the input is wrong, and a lot of other complex issues, how well does it really work, and how do you deploy it so that it actually becomes a help? And I do personally think that there are solutions which can be help, but there's a lot of them that would turn into a burden. So that is my final examples, and these are some of the webinars we have coming up talking about this topic. Another one we're going to address is heart failure, because that's a big topic, and we're just about scheduling the date for that. So that's my introduction and a little bit of context of what we're doing. Thank you very much.
Mattias, thank you very much indeed. We shall now hear from Sarah Andersson, who is a Professor of Health and Welfare Technology in Sweden and former Director General of the Swedish Public Health Institute.
Yes, thank you, Mattias, for such a good presentation. And what it shows actually is that the COVID-19 is exposing the vulnerabilities within healthcare systems and social care systems, for that matter, because public health actually is much broader, not only in the healthcare systems, but also reaching out to social care systems and other systems which are important for determinants of health. So having said that, then the framework for how to get into those digital solutions and diagnostic tests becomes very crucial, because if you don't have a system in place and the framework, how do you choose among all those tests in terms of safety and effectiveness, and also the benefits of those tests and other digital solutions, then it will be some kind of ad hoc based decisions, which makes it very difficult. So it will be like try and error. And this is why what Mattias and I started is to see how do we learn from the best examples from other countries? What are they doing? And we believe that through collaborations and changing information and knowledge, we can come a long way before we get the evidence in place.
Thank you very much, Sarah. At this stage, Bernard, would you like to comment as a health professional? You're professor of cardiovascular therapeutics as well as the editor of our journal, Postgraduate Medical Journal. You're in Hong Kong, which has been remarkably good in terms of being able to keep the numbers of cases down as well as the mortality down. Could you comment on the sort of diagnostic approach and the apps being used in Hong Kong at present?
Yes, thank you, Donald. Well, I think I read just now that there are 3 million cases of COVID-19 worldwide at the moment, which is staggering, really. And in a way, you could see that the trend has been, the rising number of cases. That trend has been going on for time. And in fact, in the early stages, it was very worrying. It was actually exponential, with a doubling time of every 3 days. So every 3 days, you have double the number of infected patients. And that's really very horrifying. And I think that, I suppose because in parts of Asia, we experienced SARS, some 15 years ago, more than 15 years ago. Therefore, I think, both the government and the people are very were very prepared for this new virus. And in fact, a lot of infrastructure is already in place to combat a new virus outbreak. Nobody could have predicted that it would be a coronavirus. We thought it may be a sort of like an influenza virus, a new influenza virus or something like that. But actually, the way you approach it is very similar, actually. And so in general, there are the sort of public health government measures to prevent the spread of coronavirus, but at the same time, the people also have to take matters into their own hands and really look after hygiene, their own hygiene, and also preventing spread for those who are infected or who may be asymptomatic, for them to take measures to prevent spreading it to other people, especially the vulnerable. Mattias has mentioned earlier on that it's so important to prevent the vulnerable from being infected. And I suppose the success of the sort of prevention story in Hong Kong was really down to a few very simple things like border closures. So borders were closed fairly early on, but that also happened in other countries, countries and places as well. The other thing is, I think people will notice the almost universal wearing of masks when people go out. I'm not wearing one now because I'm at home, but if I go out, I mean, as soon as I step out of my home, I would put a mask on, and that's expected of you. I think currently, probably about 99% of the population would be wearing a mask when they go out. And we are very lucky, actually, that we have got, at the moment, enough masks to go around. And that's because of early preparation. Even before we had, even before we saw several cases of COVID-19, people were already stocking up on masks, surgical masks, or something similar, some kind of mask. And so currently we have got quite a steady supply of masks, and some local firms and factories are starting to make masks as well. So that's one aspect. The other is really the hygiene aspect, like cleaning the environment, cleaning their homes and shopping malls, offices, toilets very frequently. So if you go to a shopping mall, you see people, you know, wiping surfaces with a disinfectant all the time. And so this is the general awareness. And because we really did all this at a very early stage, so the numbers really never went up that much. So currently we've got just over 1,000 cases altogether in Hong Kong, which is actually a very small number or proportion of the general population.
Exactly. So last week we were listening on a webinar about this European collaboration, PEP-PT, together with my Chinese colleague. And afterward he said, why did they spend half the time talking about privacy? So it's a very different contextual question of how privacy is seen. And this weekend, Germany reverted their aim to have a central proximity tracking app, rather to have a decentralized app in order to protect privacy. So that is a very important question for us to consider. How can we accomplish this while still preserving privacy in a good way?
So I do encourage you on the line, do through the chat or through raising your hand or through speaking, let me know you'd like to comment.
In the diagnostics, well, I think the issue with diagnostics is, on one hand, is shortage. That's been an issue in some countries. And the other has to do with the use case. Because if the use case is that you want to get healthcare personnel back into work, which is a dominant case, I think, in Europe, then you have one scenario. But if it is like it would suggest here in some of the Swedish experience, that you have quite a few asymptomatic patients or healthcare workers, you have a different use case where you may need on-demand daily tests in some cases to really be able to uphold the security for the vulnerable patients. So it depends on the question of the infected patients. And then obviously with the immunity question, it's another question which is still evolving the science, how to demonstrate that and to have a high quality in that. And then the thing which we then covered in the first webinar is this question: what does the regulatory CE mark, which is the approval in Europe to use a test, what does it mean? And what does that entail? And the issue is that for professional tests, it is a self-declaration by the company without any external review. So if I make diagnostic tests, I can certify that they are safe and good. And that is a quite significant issue, that we don't really have a good regulatory control mechanism in place. So that has an important question in regards when you buy maybe from unknown companies, where we don't know what are they actually giving us.
I have a question here from Ferdinand.
Hey, yeah, it's Ferdy here from University of Exeter. Thank you for a very insightful webinar so far. I just have a question for Bernard. I just wrote it down. So there's these methods you described, the wearing the mask and cleaning of surfaces, and a generally very high awareness of how diseases spread. Are these measures that have been implemented recently because of the COVID epidemic, or have these been continuously implemented since 2002, 2004 SARS, and therefore become ingrained in the people?
That's right. You're right. These things have been really around since the time of SARS and ingrained in people, as you said, Ferdinand. It's just that it's been stepped up more recently. For instance, I mean, almost everybody has, you know, some spare masks in their homes. We had, you know, when this epidemic started, I mean, we found a spare box at home somewhere. It's a bit old and all that. And also, in fact, in the last 15 years, if you go to public places, you see signs saying, oh, you know, we disinfect every 2 hours or something like that. So, I mean, this has been going on for 15 years. It's just that, you know, it's been intensified, you know, since we have this pandemic.
Sarah, I know you had a comment about ethical concerns generally. One thing that struck me looking at what's being used to track people is not just their phones, but also accessing their credit card and bank card details so they can see where people have been shopping and spending money and so on. Is that something that you think, given the severity of the disease for those who are affected, health professionals, particularly being vulnerable with apparently at least high virus load exposure, do you think this is something which is reasonable to complement the apps, or is it a step too far?
First of all, it depends on the the intention and being honest about that. And I made a comment about that. So is it like, because you can get a lot of other data by doing that. So is it that other data being corrected, and by who and for what intention? Or is it only for the now, in this case, COVID-19? And how do we protect the integrity of those who use these apps, like the Australian example? And I also looked at the Australian example, who is sending this, because it was the Australian government. And that, of course, would depend on how much people trust the governments. So the question would be, who will be the suitable person to be behind these kinds of apps? And also being very open about how the data is going to be used and for how long.
Thank you very much, Sarah. I think now we should turn to the editor of our journal, Health Policy and Technology, Ken Redekop, who is based at Erasmus University in the Netherlands. Ken is an expert on health technology assessment. As we've heard from Mattias, one of the challenges here is how on earth do you make sure that you have reliable diagnostics and in due course treatments and so on available, which are going to be robust, when it is so difficult to go through all the right steps to assess these things properly. Ken, would you like to comment on what's the feasibility of proper health technology assessment in the time of a pandemic?
Well, I think as you suggest, the system in general is not attuned to dealing with this kind of problem. I think many of the tests and the whole approach is more attuned to many chronic diseases. There's a sort of a general regulatory process, which is, as Mattias said, more primitive when it comes to medical devices and tests compared to pharmaceuticals. But when it comes to rapid assessments, this is where the whole system shows its weaknesses. I think, and I think that this is, in a sense, is important of things to come when it comes to the digital era, when it comes to real-time updates of algorithms, that sort of stuff. The pandemic is sort of a biological example of needs, the need to improve the pace at which we make these assessments, and perhaps the number of times that we will have to reassess in the future, because a test that might be good enough now might not be good enough in a year. But I think the other thing too, of course, we all know, is that the fact that if a test is good in one place and known to be good and working well in one place, it might not work very well in another because of the heterogeneity of the disease and what's causing the disease. If you don't really understand the biological aspects of it, you cannot develop a very good test. So everything hinges on everything else. I think the other issue relates to the way in which we share the evidence with other people. Right, and we cannot think about the old system, but we have to think about ways in which we can ensure that the tests are the proper tests of the tests are performed, but also the evidence is shared in a very rapid way. And I think then and that's one essential issue when it comes to the HTA aspect. I think in addition, as Sarah mentioned, the privacy means that a test may not be accepted in one place, even if it works really, really well, because of issues that go beyond effectiveness and efficiency. So that means that every system or jurisdiction will have to make their own decisions about what to do with the evidence. They might say the test works well, we don't have any issues there. We're just not going to use it because of our ways of dealing with privacy issues.
Thank you, Ken. Sarah, a related question for you. In the UK, for example, we now have NICE, which is a health technology agency, which looks beyond approval of drugs, and then to that is added evaluating diagnostics. And the FDA, for example, they quite early on with the biological newer drugs, newer approaches, moved into the idea of having so-called companion diagnostics. So that they had the idea that the regulators should look not just at treatments, but what about supporting tests, either for making sure you've got the right disease to treat, or what about monitoring risk and so on of the treatments. So with that in mind, so there are two examples, UK, USA, with mature diagnostics agencies. What's, from your background in public health and what you're dealing with other European public health directors, what's the practicality of getting new diagnostic tests through in this sort of setting that would be acceptable throughout the region, the European region?
Very interesting. In addition to what has been said by Ken, for instance, the evidence need to be there, but it's not enough. It has to be acceptable. It has to be implemented. And then we are moving into the health policy issues, which involves politics. So the politics, of course, plays a very big role. We have seen that in some countries where evidence doesn't really matter, but politics matter. So it's a matter of finding. Some countries have done well to see how you can actually meet the politics and the evidence. But in most cases, it will be the politics running over the evidence. But if the evidence can make a political case of that evidence, of course, that I mean that those politicians in power will be able to get their votes in the next election, then it will be in the right pipeline. By the end of the day, politics will play a very big role.
Thank you, Sarah. And going back to you, Ken, if you think about maturity of being able to evaluate what's happening, we've got medicines which are pretty mature. The Medicines Act in the UK, post-thalidomide, was his early 60s, for example. And then we've got diagnostics, which are much more recent, but they are being evaluated at least systematically in some developed parts of the world. And then those examples are perhaps being used elsewhere. What about the question of health apps, digital health supporting apps, as we've seen in COVID and other applications? What's the position in terms of how these are evaluated at present, and what are the gaps in that system, do you think?
That's a good question. I think digital, well, I mean, I think one thing I should definitely do is refer to Mattias, who I think has also mentioned the developments in the UK. I think that it's somewhat of a Wild West situation out there, but it has a lot to do with the function and the aspect of safety, right? So in that sense, it can be seen as a device, a special type of device. If it's not going to do much harm, then it could be less regulated. But if there's a chance it could cause a great deal of harm, then it has to be regulated more carefully. And then the question is, how can you anticipate the amount of harm it can cause? And I think that's when a lot of people have been extremely surprised by the impact of social media, which in a sense shows us how much harm, if you like, can be caused by the ICT and internet. I think similarly, in the digital health arena, I think that's when you have to be thinking about the way that benefits with the risks. But I think I'm curious about what Mattias or Sarah thinks about these issues. I mean, to what extent can you get in this phase a handle on the regulatory aspects? Because there's such a variety of different kinds of apps that are available now.
Mattias?
Yes, thank you. Well, I think, as we said, I mean, there's some things which are rather simple, and either they are the FaceTime or something like that, or it's more for the individual. But I think the bigger question is that when we start redesigning our healthcare process, it requires a new mindset. And I think we need to start thinking about disease management programs and how we integrate health. So if you want to do, like it's suggested with triaging in GPs, well, then you have to start with the very strategic question: what is it that we want to improve? Because if you look at literature, we forget to ask the question why. We think it sounds great, but what is it we want to improve? Is it to reduce cost, improve the outcomes for the patients? Why are we doing it? And then we need to measure baseline and measure the effect, but also not only to measure the primary objective, but also the undesired response that can come out of it. What happens if people give in the wrong input and get the wrong diagnosis, even though we save money? Is that acceptable? So I think we're going to need another take on coming down from disease perspective, defining the outcomes that are relevant, defining the intention. How do we want to shape this? What do we want to accomplish? And then measure, and then make sure it happens. And then, to me, it's rather what I would call a disease management tool. It doesn't matter. It could be a diagnostic, it could be a digital, but it's accomplishing the measures you're after in regard to the disease. And I think that's the big question for the future, because you can't really observe this as standalone events.
Thank you, Mattias. We have a question from someone online, Jiamen Zhu, who is a clinician researcher from China, Singapore. And he notes that with relaxing lockdown, there's been a second wave. And the question really is whether, despite the control measures, nonetheless, there could be herd immunity. I suppose that's being pessimistic in saying that eventually people will be exposed in large numbers, and perhaps herd immunity might be an aspect. Now, there are so many topics we could cover in relation to COVID-19, and it's really beyond the scope of today to go into that in detail. However, undoubtedly, we need reliable diagnostics to know who's actually been exposed to the disease. We also need knowledge from epidemiologists whether any immunity is long-lived. You know, for example, coronavirus is a cause of 11% of the common cold symptoms people experience, a different kind of coronavirus. And the observation is that many people will only be immune for 3 to 4 months. So it may be very difficult to be able to answer that question as a long-term consequence. But Mattias, you want to pick up on this specifically about diagnostics and to what extent detecting herd immunity may be realistic?
I don't really know about. I mean, that's one of the million-dollar questions, I would say. But coming back to this with evaluation frameworks, it's basically NICE in the UK who has a framework specific for diagnostics, and UNETA. But many countries haven't really developed a specific HTA framework for that. There is for drugs, sometimes for devices, but very rare either for diagnostics or for digital.
Mm. I mean, as a clinician, over my time in acute medicine, I've seen a whole range of different infectious diseases with problems and solutions. But with this current outbreak, the risk is that we have a lot of people out there who are at increased risk, and they're the ones who seem to be more likely to be in hospital, more likely to be in intensive care. We've got a worldwide epidemic of diabetes, and if you've got diabetes mellitus, you've got a 3-fold excess chance of being in hospital and being ill with it. So because of the worldwide diabetes epidemic, that's one of many reasons why we should worry. And even if you have this herd immunity, really is a term which relates in modern terms to vaccination and what proportion of the population have to be protected through a vaccine before you're protecting most people. And I think in practice, because so many people are potentially at risk, they're so high risk that this coronavirus, maybe like others, and not lead to sustained immunity, that really what we're talking about is intense control measures, diagnostics, apps to support tracking, and then getting a decent vaccine available as soon as is practical. Mattias, any comments on that?
No, I think you're right that it's very hard to know about the herd immunity, and it is an array of activities needed. And I think that the thing that is that we're going to get into the new normal, and we need to learn how to live with that. So I think we will have to transform behaviors for a long period of time and figure out either if we have had lockdown or not, but how do we live after the intense period to ensure the continued safety. And we will need good tools for that.
Hmm. So any further comments in response to Mattias there? Learn to live with the virus?
I think I think what we're probably talking about is like you can view it like a restaurant. You go in there, and if nothing is served, you have to choose or you have to find your own food, so to speak. But as these tests and these apps and different options become available, then I think what you will see, we've already seen it now, is that different countries will choose different measures, and as the quality of the different options improves, they're going to choose, but they're not necessarily going to choose the same thing, right? They'll choose a better apps maybe to control their part of what's going on in their population, but they won't. What they do in their own jurisdiction may differ a lot from what neighboring countries may do. We've already seen this. So test might be the option in other, but Sweden has been also one of the semi-controversial countries because they want to keep their economy growing, partly because of the culture and attitudes. So the question is whether or not parties like the EU can require different the different countries to do the same thing with the available apps. I don't see that happening, and that to me is the disadvantage of individual freedoms in different countries. Despite even if apps are available, they might not get used. That's what I think. And I think that we're talking about phases, right? In which we have one phase with measures followed by another phase of measures, and it's a holding pattern until vaccines become available. That will be the general situation in the whole world, I think, for the coming 2 years or so.
Bernard, any comments from your side?
Yes, I want to comment about the privacy issue that you raised earlier. Interestingly, in China, where there's a lot of technology being used to identify people and trace people, and people have to use real names on the internet and so on. And one of the side effects of that is that it's actually very, very easy to locate somebody. And I believe that this technology has actually been put into use to control, as part of the measures to control the pandemic. On the other hand, it's more difficult to implement in other jurisdictions. I mean, Hong Kong is an example where I think the population would be very resistant to be watched over. So I think each country or jurisdiction will have to make their own choices, with regard to that matter.
Any further comments from you, Sarah, on what we've heard from the other speakers?
Yes, I would like to comment on what will happen after COVID-19 and what we learn. We're going back to business as usual. I think it's going to be such an interesting research area, because what it has done is to expose the vulnerabilities within the systems, but also to show the vulnerable populations that maybe we haven't given much attention to. The elderly, people with the comorbidities of different kinds of risk factors, and also exposing the social inequalities. And I think what it does now is for us to start to think in terms of broader determinants of health and how do we deal with those. And Mattias mentioned on disease management, that maybe we need to think more about disease management and promoting health, so that way, whatever will come in that kind of same manner, this virus, it will be much easier to tackle these things. And not to mention the rapid assessments that Ken talked about, because we have a behavior of waiting to do things taking a longer time. So how do we do them much faster, but also addressing the evidence, safety, and reliability of different diagnostics and digital solutions?
Thank you very much, Sarah.
A very quick comment. I want to take sort of follow on what Sarah said. I think after this epidemic or pandemic, we are going to have to tackle obesity and obesity-related diseases like diabetes, hypertension, and coronary heart disease, because these are also happen to be risk factors, to have a severe COVID-19 infection. And so, we'll have to, I'm sure we'll get out of this pandemic, but after that, we'll have to, focus again on those chronic diseases in the population, very prevalent in the population, which would increase, the risk of infections rather like COVID-19.
Thank you, Bernard. Ken, did you have a final comment?
No, I want to say there was a comment that Cheung had sent in. If it maybe I can ask you, Yichi, to ask it directly.
Hi, I'm a student in Singapore, and Singapore has developed a few apps, for example, Trace Together for contact tracing, and also there's another app called One Service to report those people who don't follow the social distancing, and also we have a website to check the number of people in shopping malls to avoid crowds. But the app, it seems that the app usage is not quite good. So I think how to improve the app usability is a problem. And another problem is, so besides data privacy, how can we make sure the user's information provided is true, it is authentic? For example, we want to make an app for teleconsultation app for COVID-19, and this disease is infectious. And if we find the user is suspected, or even we can almost confirm that he's the patient, but how can we find this person? So this is my problem. But how can we make sure they give us the true information? For example, I'm very panicked. I don't want to be quarantined. So maybe I will just check online, but I don't give the real information.
Yeah, I think this is a question which is then quite different in different cultures and settings, where if you have a country where you have legal enforcement of things, of course you have more of the risk of hiding the true answers because you don't want people to know. So I think that's an inherent problem if we want to have free society, that we have to allow for the risk of errors in regards to the privacy of the individual. The other aspect that you mentioned about the improvement of these solutions, I think normally that there is a usability evaluation you should do when you do these apps, and continue, which you should detect these issues and to have a continuous development. I think many of these specific apps has been developed in a crisis mode, so there hasn't really been a plan. And that's what I hope that many countries will learn from the apps, because it's one thing to throw out an app that may or may not work well, but then how do you optimize the performance so that you really accomplish the result you're looking for? And that, I think, is missing in many countries. How do you get to the final result?
I think that the one way to do it might be to think about healthcare credits, right? I mean, in some sense, I mean, you're participating in that process not because you're going to get something out of it immediately, but it's a bit of element of altruism, but you're going to benefit in some way, hopefully, or you're going to help society benefit. So why not just say, okay, 50 cents or like the equivalent of $1 or whatever that you would be receiving by just installing and using your app, right? In that sense, you at least but you don't have to simply rely on the voluntary participation. I know, like I just mentioned, in Australia, I think I heard 1 million in the first day, but that was far beyond expectations. But they need something like 10 million downloads for it to do any good. and it'll be interesting to see how quick the uptake will be in the coming week. But I'm sure that that's going to differ between cultures. You know, you cannot expect that to happen everywhere.
We're now at the end of this webinar. I should like to close by thanking all our speakers and discussants. You can find out more about these monthly webinars, which are free and from the FPM, by going to our website, thefpm.org.uk, for information about future topics and how to register.